I think we're going to have quite a few people here today, so that's exciting. All right, well, I think we'll go ahead and get started. Thank you all so much for coming to our speaker series today, and I am honored to introduce our speaker. Dr. Judy Heidebrink is the director of the Neurology Cognitive Disorders Clinic and is the co-leader of the clinical core of the Michigan Alzheimer's Disease Research Center. She has been involved in collaborative clinical trials in dementia for over 20 years, including phase 1 through 3 studies focusing on the prevention and treatment of Alzheimer's dementia. In addition, she has led the University of Michigan's participation in the Alzheimer's disease neuroimaging initiative since the inception of this longitudinal observational study of brain images and other biomarkers in the progression from normal aging to dementia. I am very pleased to have Judy Heidebrink with us today.
Well, good afternoon, everyone, and thank you for joining me to hear this update about clinical trials in Alzheimer's disease. You probably know from the news that there have been lots of reports regarding recent information from clinical trials in Alzheimer's disease, so this topic could not have been more timely, even if it did mean updating my slides literally on a weekly basis as some of these news releases are coming in. So here's what I'd like to go over today. I'll just start with a little bit of background information about clinical trials and the focus of the ones that I'm going to review today, and then spend a fair amount of time about the trials looking at the anti-amyloid antibodies, because those have really been in the news in particular lately. And then I'll just give some brief highlights about some other clinical trials that aren't necessarily targeting amyloid or using the anti-amyloid antibodies. So just as a reminder, what I'm going to focus on today are clinical trials looking at potential treatments for Alzheimer's disease. But Alzheimer's disease is one of many potential causes of dementia. So dementia is a syndrome where individuals experience changes in their thinking abilities that impact their daily activities. Alzheimer's is the most common cause of dementia, particularly later in life, but it's not the only cause of dementia. So some of the other causes of dementia are pictured here, and it's important to pay attention whenever you're hearing information about clinical trials to know whether the trial was focused specifically on persons with Alzheimer's as a cause of their dementia or cognitive impairment, or whether it was a different type of dementia, because treatments against the specific pathology of Alzheimer's, like the plaques and tangles, wouldn't necessarily be expected to have an impact on a different type of dementia that doesn't have plaques and tangles, for example. Some studies, though, might look more broadly at ways to protect the brain from loss of nerve cells in the setting of any number of dementia causes. So some potential therapies might be studied in more than one type of dementia. But again, I'm going to focus today on clinical trials related to Alzheimer's disease. And so you heard Stephanie mention that at the University of Michigan, we've been involved in trials in different phases. What are these clinical trial phases that she mentioned? So before any type of medication is reviewed for approval by the Food and Drug Administration, it typically goes through a series of phases of clinical trials. And they are ordered numerically: phase 1, phase 2, and phase 3. And they basically expand in terms of the numbers of individuals participate, how long they're being given the treatment, and what type of measurements are being looked at. So the first time a drug is given to a human, after it's gone through some early studies in animals, for example, the first trial in humans is a phase 1 trial. And the real question is here, is this medication safe? It's been looked at in animals. We think it might be promising for a particular disease, but if it's never been given to humans before, we just have to start out by saying, is this safe? And how much can someone take? How long does it last in their body? Does it need to be given every day, every week, multiple times a day? So these are very early studies looking at how the drug gets into the body, where it goes, how long it lasts, and are there any side effects of any type? So sometimes in these initial phase 1 trials, healthy individuals are picked just to be able to study the metabolism of the drug. It might be older adults if ultimately the study is going to be used to, if the drug is going to be used to treat a condition that's more common in older adults, but sometimes to begin with, it's younger, healthy adults, just to be able to see how someone tolerates it, how long it lasts, and really is it safe and at what dose and duration. So these might be small numbers of individuals. They may all get the active drug. There might not be a placebo for comparison. And depending on the type of drug, these studies might just last a few days for a few weeks. And as long as the medication looks like it's safe and there's at least some doses that look like they might be useful to carry forward, then a phase 2 trial starts to introduce a larger number of individuals. These are typically persons who have the condition for which the treatment is being studied. And you still want to know, is it safe? But this time individuals are given a more standard dose over a longer period of time to see, again, how do they tolerate over a longer period of time? And is there some initial evidence that it might be helpful for the condition for which it's being studied? So this might have a few hundred patients, and they might be taking the intervention for several months with really trying to learn, does this drug look like it's potentially beneficial? And then sort of the pivotal trial is at the phase 3 stage, where even more individuals are given the medication, often again with a placebo group at this point. Phase 2 and phase 3 typically have a placebo group, so you can compare if we're seeing something, is it because of the drug or is it just by random chance? To learn that, you really need to compare the active drug versus a placebo. And again, this would be many individuals over a longer period of time to really answer the overall question, is there a benefit to this treatment in this condition that outweighs any potential risk? So these might be longer term trials, many months or even a few years, just depending on what type of condition is being studied. So today I'm going to focus on a lot of the phase 3 information, because again, that's sort of the pivotal stage to decide, is this drug ultimately going to be helpful and potentially be approved by the FDA? So as I mentioned earlier, a lot of the trial information in the Alzheimer's disease realm has been with compounds that are targeting the amyloid plaque buildup that happens in the brain when someone develops Alzheimer's disease. And so there are a handful of medications that are called monoclonal antibodies. These are antibodies that can get into the brain, bind to the buildup of the amyloid protein, and help the brain's immune system remove that amyloid protein from the brain. And so all of these, they have somewhat unusual names, but they end in MAB, which stands for monoclonal antibody. So any drug that ends in MAB is an antibody. Not all MAB medications are anti-amyloid antibodies, but this slide shows the family of amyloid antibodies that have been used recently in clinical trials. And this just shows how the amyloid protein in the setting of Alzheimer's disease, it starts to form first smaller and then larger clumps that eventually turn into these more dense plaques that build up in the brain. And depending on the specific antibody, some of these antibodies are geared to bind to the more initial clumping stages. Some are geared to design to the more dense plaque aggregations that occur in the brain. It's not clear yet whether it matters what stage that the antibody binds to, but there may be some reasons that that could be important. But all of these have been studied as potential therapies for Alzheimer's disease in people with symptoms. And as you may know, one of them, called Aducanumab, was approved as a treatment for Alzheimer's disease in the early symptomatic stages. It was approved by the FDA back in June of 2021. And as you can see from this picture, it's different from all of the medications we were previously using that were pills. This is an intravenous medication because the antibody doesn't come in a pill form and can't get into the brain in a pill form. So it's delivered intravenously, gets into the brain, binds to the amyloid plaque to help it remove it. So what do we know about Aducanumab, the drug that was approved back in 2021? Well, in its initial phase trials, they looked specifically to see, does this drug help do what we think it can do? And that is remove amyloid buildup from the brain. And so this slide shows the results of one of the early phase trials of Aducanumab. In this case, all the individuals had the condition of interest because they were looking to see, can it remove amyloid? So you had to know that individuals had amyloid in the brain. So this study was done in about 165 individuals with either very early symptoms at the mild cognitive impairment stage or mild dementia due to Alzheimer's disease. And all of the individuals underwent specialized brain scans that showed they had buildup of the amyloid plaque protein. So the left-hand column here, these are just some of the specific amyloid PET scans before the start of the study. They use a tracer that gets into the brain, and if there is amyloid buildup there, the tracer will bind, and the visual signal of that is this red, bright red coloration that indicates the tracer's binding. So all these individuals had evidence of amyloid buildup in the brain at the start of the study, and they were randomly assigned to receive regular infusions of Aducanumab, essentially on a monthly basis for a year, and they could receive either the placebo or one of 3 different doses. And they looked to see at the end of the year, what did the PET scans look like? And the individuals who received the placebo essentially showed a similar degree, if not perhaps slightly higher amount of amyloid buildup in the brain. Whereas the individuals receiving the active drug, you could see a dose-dependent removal of the amyloid. So the individuals receiving the highest dose had what essentially looked like a normal PET scan. There really wasn't detectable binding of the tracer. So it was clear that this drug could do what it was intended to do, get into the brain and help remove the amyloid. However, in addition to seeing a dose-dependent benefit or effect in terms of removing the amyloid from the brain, there were dose-dependent side effects, and those were often picked up on standard MRI scans, where at higher doses in particular, some individuals developed either small amounts of swelling as sort of fluid was shifting into the brain, or tiny areas of bleeding, what are called microhemorrhages. And those were detected more commonly among individuals who received the higher dose of the drug. So the question has been, is the benefit of removing the plaque, is it more important than the potential side effect of this bleeding or swelling? A lot of times that bleeding or swelling was clinically silent. The people who had those radiologic changes didn't have any symptoms, but in some cases they did. As a group, those radiologic changes are called ARIA, it stands for amyloid-related imaging abnormality, because again, they're often detected on imaging scans, on brain scans, even if the individual isn't experiencing symptoms. So the big question was, is removing the amyloid actually beneficial to the individual, or does it just make a PET scan look better after a year of therapy? So Aducanumab actually they skipped sort of the phase 2 and went directly into 2 large phase 3 studies, specifically designed to try to answer the question, what is the benefit of receiving this drug, removing the amyloid from the brain? And again, what are the potential risks in terms of the ARIA or any other types of side effects? So 2 large studies were designed to answer that specific question. Together, they enrolled more than 3,000 individuals. Again, these individuals all had early symptoms of Alzheimer's, either in the mild dementia stage or in the mild cognitive impairment stage. And they all had evidence of brain amyloid buildup by undergoing studies such as those amyloid PET scans. And they were randomly assigned to receive either placebo, a low dose, or a higher dose. And the intention was to follow everyone over a year and a half to see if there was a difference in terms of the dementia or mild cognitive impairment, a difference in their cognitive symptoms over that time frame, depending on whether they got the active drug versus the placebo. And the main thing that they looked at to determine whether the drug was having an effect was a rating of someone's cognitive impairment. And this rating is something called the Clinical Dementia Rating Scale. It's not something that's typically done in the setting of a standard clinic visit when someone's being followed for Alzheimer's disease dementia. This is a more lengthy interview, both with the person experiencing the symptoms and someone who knows them well, a close friend or family member. And the interview asks questions about how they're doing in terms of tasks that involve memory. Do they seem to know in general the day and date and where they're at or not? How do they do out and about in the community? Are they able to function independently, go run errands, things like that? Or do they need regular assistance? And how do they do in the home environment in terms of their household activities or hobbies? And what about their personal care? And so both someone who knows the individual well and the individual, him or herself, are interviewed and tested as part of that interview. And in the end, the rater makes a decision about whether they are seeing impairments in one of 6 different areas and how much of an impairment they are seeing. So if this individual is felt to be functioning perfectly normally, they would get a rating of 0 in each of their areas. Their memory isn't changing. They're well-oriented. They know where they are. They know the time of day. Their judgment seems intact. They can function independently in the community, at home, and in their personal care. They get a rating of 0.5, that suggests there's been a mild change. Maybe they don't forget things entirely, but some of the details. Whereas if they're rated a 1, recent events are really slipping from their memory. They might not remember them at all. For example, for orientation, maybe they're off on the day or date frequently. But if they're rated a 1, they may not know the month or the year. But they still might know where they are. If they are confused about their location, they might merit a higher level of impairment. So in the end, each of these areas is rated, and you can either create a global score by, in the sense, averaging them, or you can just sum up their total score and see what's their total score. A higher score would be more impairment. So individuals who are maybe still functioning independently, but not quite at the level they were before, they may get a lot of 0.5s. Individuals who are starting to need assistance may get a lot of 1s. And then you just track these scores over time to see how they do and compare this in the treatment group and the placebo group. Well, it gets a little more complicated because in the end, these large phase 3 studies were halted before their intended completion date because they did an interim analysis that predicted the drug would not show a benefit in the 2 studies combined. But when they looked at the data after they had halted it, so not everyone had made it through to the 18-month time point, but they looked at the data that they had accumulated, and lo and behold, the 2 studies ended up giving somewhat different results. So in the eMERGE study, if you tracked that score on the Clinical Dementia Rating Scale, and in this graph, a higher score is higher up on the y-axis. So as these lines are increasing, that means a higher CDR score, which means more impairment. So in the eMERGE study, the higher dose group didn't have as much of an increase in their CDR score as the placebo. So there was a difference of about 0.39, which is about the difference between 1 box here and here. So not quite a full half point, but it means that an individual might have stayed in this box instead of shifting to this box over the course of the study if they received treatment, but all of their other boxes changed the same way. Another way of looking at it is that the high dose treatment group was functioning at a level that the placebo group was functioning at maybe 4 to 5 months earlier. So it's as though it slowed that decline by 4 to 5 months over the 18 months of the study. So it suggested a benefit in slowing down the progression of the symptoms in one study, but in the other study, there wasn't a detectable difference. So the CDRs, the scores, people were progressing, gradually declining, whether they got the high dose or the placebo. And so the question was, what does this mean? Does the drug maybe work, sometimes work? There are a lot of technical reasons why these different results may have occurred, but ultimately we don't know. Well, you might say, gosh, even if we don't know if it's clearly helpful, even if there's a chance it slows things down, it might be worth it for a disease that we know progresses without therapy. But we have to balance that with the side effects. And as I mentioned before, with the monoclonal antibodies, we know when they get into the brain and bind, there can be some associated swelling of the brain tissue or bleeding. And in this case, with aducanumab on the high dose, 40% of individuals had at least radiologic evidence of either the swelling, the edema, or the hemorrhage, or some combination thereof. Most of the time, it didn't cause symptoms, but about a quarter of those who had detectable changes on the scans did experience symptoms that kind of correlated with either where that swelling was. So if the swelling was in the back of the brain, they might experience some visual changes because that's where our brain processes visual information, or just from the swelling, no matter where it occurred, they might develop a headache or nausea or things like that. So in these individuals, often the dose had to be stopped and they had to be monitored to see if those symptoms recovered. So what do you do with information that says the drug may or may not have a benefit, but it does have some known side effects? Well, what the FDA did was they granted approval, but through a mechanism that's a little different than the traditional approval. They granted what's called accelerated approval, which is a conditional type of approval that's based on a drug's biological effect. And I think it's very clear this drug has a biological effect. It can remove the amyloid buildup from the brain. But with an accelerated approval, that biological effect is hoped to be translated into a clinical effect, but that doesn't have to be established yet. So when an accelerated approval is granted, there is typically a requirement to have an additional study to confirm, does that biological effect really translate into a clinical benefit or not? And so there is an additional trial underway to try to see ultimately, does this drug have a clinical benefit? But given that it's only a conditional approval, Medicare last year decided that it would not cover it except in the context of a clinical trial to really help understand, does this drug have benefits that outweigh the risk? Which means for all practical purposes, we aren't prescribing this medication because it's not covered by insurers. So it's really only continuing on in clinical trials. And in fact, many institutions individually reviewed the risk and benefit information and decided there wasn't enough benefit to outweigh that risk to offer it. And so again, its use is really restricted at this point to clinical trials. But again, it is approved by the FDA for individuals at an early symptomatic stage of Alzheimer's, either mild cognitive impairment or mild dementia. But it needs to be given very carefully. For example, individuals need to be able to be followed with the MRI scans to look for some of these radiologic findings to be able to adjust the dose or halt the dose if that's appropriate to do so. So that's kind of where we stood last year. But what's been the more recent development? Well, now if you've been hearing the news, you've heard about a drug called Lecanemab rather than Aducanumab. And some people might say, well, Lecanemab, is it just the French version of Aducanumab? No, it's a different drug, but it's the same idea. It's another monoclonal antibody. And just as with Aducanumab, it did an early study to look to see what is the effect of this drug on the amyloid buildup in the brain. And so in this study, individuals had amyloid PET scans, were assigned to different doses of the drug, and lo and behold, they also showed a dose-dependent removal of the amyloid plaque. So they didn't publish nice pictures the way the Aducanumab study did, but they published their graph showing the drop in the amyloid buildup that was most impressive with the highest, most frequent dose, and less impressive with lower or less frequent dosing. And so based on this biological effect, the FDA just granted Lecanemab that same accelerated or conditional approval that Aducanumab received previously. So this again has been approved by the FDA because it has a biological effect in a disease that doesn't have good therapies at this time. So the hope is further studies would be able to be done to show that not only does it reduce the amyloid, but it has a clinical benefit. Well, in fact, one of those studies has already been done, just not reviewed yet by the FDA, but the results of it were just announced in the last few months. This was a phase 3 trial called Clarity, and as the name implies, it was designed to give clarity, does this drug have a clinical benefit, not just a benefit in terms of changing a PET scan. And so this phase 3 trial, nearly 1,800 individuals, all again in an early symptomatic stage of Alzheimer's disease, They were followed over time and compared with that same clinical dementia rating scale outcome measure. Now, for their publication, they flipped it so that as the CDR score is increasing, you actually fall further down on this graph. And so falling down means that the dementia is worsening or the cognitive impairment is worsening, but you see a difference between the group who received the placebo. Their decline was greater at the end of the 18 months compared to the group receiving the lecanemab. And that absolute difference on that CDR scale was about 0.45. So again, sort of one box different on the left-hand side of the scale, but that did represent a 27% slowing of that rate of decline. One thing that looks even more promising is that these curves or these lines seem to be separating more as time goes on. So it's possible if the trial had continued more than 18 months, you might see an even greater separation between the treatment group and the placebo group. We don't know that because the trial did end at 18 months. But at this point, we can say if an individual had been coming in and getting infusions of lecanemab, in this case, they are infusions every 2 weeks rather than the monthly infusions with aducanumab. But at the end of those 18 months of infusions, they would be functioning roughly where the placebo group was functioning at about 12 months. So it appears to sort of, again, slow that decline by about 6 months over the 1.5 years or 18 months of the trial. So you could look at it as saying, if someone was doing something independently, if they receive the treatment, they may be able to keep doing that for 6 months longer than someone who only received the placebo. What's the downside again? Was there any evidence of ARIA? Yes. Swelling and small bleeding did occur. The rate was lower than in the aducanumab trial, so it was about 22%. And in most cases, again, it was clinically silent. It didn't change people's day-to-day function or cause any symptoms, but in a small percent, there were symptoms. And this data will all be reviewed by the FDA to determine whether to grant the drug full approval or not. And we'll have to wait and see, do insurers like Medicare, will they continue to approve it only in the context of clinical trials, or will they say, yes, we'll approve it for regular use if the FDA grants full approval, or if they review this information as well. They did look at other outcome measures too, besides that clinical dementia rating scale. If you looked at the PET scans, again, a dramatic dropping of the amyloid on the treatment group compared to the placebo. If you looked at other clinical measures, these are either tests of thinking or measurements of day-to-day activities. All of them showed less decline in the treatment group compared to the placebo. So really consistent evidence that there is a difference between lecanemab and placebo. Unfortunately, it's not a major difference, it's more modest, but it does appear to slow that progression. Again, we need to balance that out against the potential side effects, which were not equally experienced among all members of the trials. It turns out that those individuals who carry a specific genetic risk factor for Alzheimer's disease, called the apolipoprotein E4 genotype, those individuals, particularly if they have 2 copies, if both of their ApoE genes are the type 4, they had a much greater likelihood of experiencing the ARIA types of side effects. So if they divided the likelihood of detecting swelling on an MRI scan, if you didn't have any copies of the ApoE4, it was only 5% compared to if you had 2 copies, it was up at 30%. And 10% of the time that, or almost 10% of the time, that led to symptoms. So this has really led to the thought that if we do offer this medication, we will really want to know who genetically is going to be at a higher risk of some of these side effects, because that may change ultimately the decision about whether to pursue this type of treatment. But in the end, we say, gosh, is this going to be a practical way of treating most individuals with early Alzheimer's symptoms, coming in every 2 weeks for infusions? That's a lot of time and logistics. Are there other ways of making these types of therapies more realistic to be used on the numbers of individuals experiencing this condition? Well, one of the other antibodies, gantenerumab, was studied in a subcutaneous form, so just small needle injections under the skin that could be given at home and potentially even be administered by someone in the home rather than needing to come into infusion center. So there was promising hope for this as a more straightforward or a logistically more feasible way of treating individuals. But unfortunately, in its large phase 3 studies, they didn't show any significant slowing of decline. And it turns out that the amyloid removal, when they measured it, was lower than they expected, suggesting this drug just may not have been powerful enough to either see the benefit in amyloid removal or a clinical benefit. So it really hasn't been seen as an option. There's another drug that the FDA reviewed just last week. It's another monoclonal antibody called Aducanumab, and it looks like it can remove plaque very quickly. They actually interestingly did just a PET-only study looking at PET scans before and after 6 months of treatment with their drug, Lecanemab, and that previous drug that I mentioned, Aducanumab, and we're able to show that in 6 months, there was much more plaque removal with Lecanemab compared to Aducanumab. Well, why is this important? Well, one thought was maybe you don't have to treat someone with this drug as long as you might have to with some of the others. Maybe you can remove that plaque rapidly and don't have to keep dosing once that plaque is gone. So it may not be 18 months of therapy, maybe it's only 6 or 12 months of therapy, and then you can stop dosing when the plaque is gone. We don't know yet whether that will truly have a clinical benefit because those trials are ongoing, but this was submitted for the FDA to review to see if they would grant it accelerated approval. Again, accelerated approval saying, does this drug have a promising biological effect in terms of amyloid removal? And interestingly, the FDA decided not to grant approval, not because they weren't convinced, I think, by this type of data or other data were submitted, but they said, gosh, there haven't been enough people on the drug for long enough periods of time. Very few people have been on this drug for a year, for example, and in some cases, you might need to give it for a year to fully remove that amyloid plaque. But in some ways, because the plaque has been removed so quickly, they didn't have enough people on the drug for a year for the FDA to say, we've seen enough safety data about it to feel comfortable approving it. So the FDA declined to grant it accelerated approval, but these phase 3 trials looking at not just plaque removal, but clinical benefit as well, are expected to release their results later on this year. And so the FDA will then likely review it to determine if it should receive traditional approval. So we might have yet another potential therapy in terms of a monoclonal antibody. Again, some benefits slowing the disease, we hope, but some risk as well. So these need to be balanced very carefully. So in the end, you say, well, gosh, if we can get rid of amyloid from the brain, and we know that's one of the hallmarks of Alzheimer's, why aren't we getting a more dramatic effect? Why aren't we really halting the disease or reversing the disease? And the answer is we don't know, but one possible reason is by the time we're giving these drugs to people with symptoms of either mild dementia or mild cognitive impairment, the amyloid plaque has really been building up for many years in a silent phase. So that amyloid pathology begins before the symptoms are ever apparent. So by the time we're treating individuals who have symptoms, we're trying to address a problem that's been changing in the brain for several years. So maybe it just isn't going to be enough once people have developed the symptoms of Alzheimer's disease. But potentially, maybe there would be a greater benefit. Maybe you could forestall symptoms, not just for 6 months, but maybe for years or more if you delivered these treatments as people were starting to develop the plaque rather than many years later. So that, in fact, is the question that's been posed to a lot of prevention trials using these same monoclonal antibody agents. So many of the ones that I just mentioned have either been studied in trials in individuals at risk for Alzheimer's. One of them, unfortunately, didn't show a benefit, but the dosing was felt to probably be too low at the time. When the Gantenerumab data that I presented earlier, when it didn't show a clinical benefit, the company decided to sort of stop development, so there isn't going to be a prevention trial with it. But both Lecanemab and Aducanumab have trials in individuals at risk for Alzheimer's to see if giving infusions early on can prevent the risk of those symptoms emerging. And there's a trial that has been going on for several years using another monoclonal antibody called Lecanemab, and we expect to hear the results of that trial later on this year. So stay tuned. And I will just mention that we are currently participating in this, so we hope to hear the results, release those results in the next several months. And we're currently at the University of Michigan recruiting individuals to participate in the Lecanemab prevention trial. It's called the AHEAD study, and it's looking for individuals who may be at risk for developing Alzheimer's symptoms later in life, partly just because they're aging. We know that's a number 1 risk, but also maybe if you're younger but have a strong family history, or you know you carry one of those genetic risk factors like the apolipoprotein E4 gene, that would enable you to be screened for this study. Ultimately, individuals in this trial will undergo those amyloid PET scans to see if they have amyloid silently building up, and depending on the level of that buildup, they'll receive the active drug or placebo either on a essentially monthly basis or every 2 weeks. So pitching the more frequent infusions to individuals who have a higher level of amyloid buildup, and the less frequent infusions to those who have a more intermediate level of buildup. But this trial is also unique, but besides just being a prevention trial, it's actually doing a pre-screening stage before people get to the amyloid PET scan stage by looking at blood levels of amyloid, because it turns out you can measure very, very tiny quantities of amyloid in the blood that can give you a reasonable indication about whether amyloid may be building up in the brain. Now, these tests aren't perfect yet, and so they're just being used as an initial screen to say, is there some chance we might find amyloid in the brain based on this blood result? And if so, those individuals can move forward to have the PET scan. And we know in many cases, the PET scan may not show any buildup, so the blood biomarkers aren't being used as a substitute, but just as a way to take an initial look and see, can we refine who needs to have the PET scan based on a blood prediction about amyloid buildup. And so individuals in the study will have regular PET scans, regular MRI scans for safety reasons, and tracking to see how their cognition does over time. They're all starting with normal thinking abilities, and we want to know, does treatment change the course over the next several years in terms of whether they develop cognitive symptoms or other types of changes? So let me spend a little time now switching gears away from amyloid. Again, that's where all the big news has been lately, but just at least mention some of the other types of studies that are out there in Alzheimer's disease clinical trials. Some of them have focused on the other main pathology in Alzheimer's disease, the tau protein that builds up in the form of the tangles inside the nerve cell compared to the plaques that are building up outside the nerve cell. So why might that be an important target? Well, it turns out that the tau pathology actually correlates better with the loss of nerve cells and the clinical symptoms compared to the amyloid pathology. As you could imagine from what I've already said, people can have a lot of amyloid in their brain and it can be completely silent. That's why they're being enrolled in prevention trials, because they aren't having symptoms, but we're trying to prevent those symptoms. But when tau starts spreading in their brain, that's when symptoms really start to develop. And so perhaps targeting the tau might help people who are already exhibiting the symptoms, and may be more effective than targeting the amyloid. Maybe the amyloid treatments need to be earlier, but the tau treatments could still be given later. And in fact, it turns out in at least animal studies, you can have a lot of amyloid in your brain, but if you control the tau, you might be able to prevent or modify those cognitive deficits. So that was the conclusion of this study from years ago, where essentially laboratory mice who are genetically engineered to develop a form of Alzheimer's, they could manipulate whether amyloid or tau became expressed in their brain. And they looked to see, could a mouse learn the position of a submerged platform in kind of a milky pool of water? Because the mice don't like swimming around constantly. They want to find that platform and rest. And so they put them in this container, which has some basically has some landmarks they can look around and sort of decide where they are. And once they learn where that submerged platform is, the next time they put them in the container, they look at the landmarks and say, aha, I know where to go to find that platform, if they can remember it. So a normal mouse, after they've learned it, is pretty much spending its time right where the platform is. But a mouse that has a lot of amyloid and tau in its brain is really randomly swimming around the different quadrants, can't find that submerged platform. But a mouse that's not allowed to develop the tau buildup, but can develop the amyloid buildup, still can learn where that submerged platform is. So again, the tau may correlate better with the cognition. So tau therapies may help people once symptoms have already been present. So where do we stand in tau therapies for Alzheimer's disease? Well, just like there are amyloid antibodies, there are also tau antibodies under development for Alzheimer's disease. Unfortunately, the studies so far have not shown great promise as they've moved along from phase 1 to phase 2, for example. So many of the ones that have been studied so far have not shown a clear clinical benefit. One drug showed a slight difference at the very end of the study on one measure, but not on any of the other measures of cognition. And the thought might be that not all tau antibodies are equally effective. It may depend on what part of the tau protein the antibody is targeting. So other antibodies aimed at different sections of the tau protein, or other immune approaches, vaccines that allow you to develop your own tau antibodies, those are now moving forward in clinical trials. So we'll have to stay tuned to see if those are potentially more effective. And there have been a lot of other agents trying to block just the buildup of the tau itself, not by an antibody to remove it, but just preventing the tau from accumulating in the form of tangles. So there's a company that in fact is so dedicated to tau therapies specifically. It's called Tau RX. So they're really looking at therapies for Alzheimer's that target tau. And they've looked at compounds that, again, are thought to be able to prevent the accumulation of the tau in the form of the tangles. And the most recent compound they studied, it goes by a name that is too long to pronounce. So it's abbreviated HMTM, but it's an oral compound, so it doesn't have to be given intravenously. It's chemically related to a dye called methylene blue. So one of its interesting side effects is that someone takes it by mouth, it will turn body fluid, specifically urine, will turn blue. And so it makes it very easy to know if you're taking the active drug compared to a placebo, which has always made it a challenge if you want to do comparative studies. So in their phase 3 trial called Lucidity, they gave individuals either the HMTM or a related compound that was meant to function as a placebo, but had still that blue chemical effect. So people couldn't tell whether they were getting the active drug or the placebo just by that blue coloration. And so in the end, when they compared how cognition changed in individuals with different levels of cognitive impairment from Alzheimer's, they didn't see a difference between those taking the HMTM and those taking the MTC. But as it turned out, when they started measuring blood levels of what they thought was the active component, they could detect it both in those who received the HMTM and in those who received what they thought was the placebo. So maybe it wasn't that the drug didn't work, it's just that both worked, and so you couldn't tell the difference. So this is going to need some further thought to tease that out, because it's really hard to make a comparison if both people are getting sort of active treatments during this study. So tau, I think, is still a viable approach. We just need more information and more compounds. But there have been some really interesting studies presented recently, not clinical trials in humans, but some researchers are focusing on tau changes in animals. It was known from previous studies that tau can accumulate in the brain of hibernating animals in a way that's similar to how the tau tangles build up in humans when they experience Alzheimer's disease. They get these tangle-like structures. This was known from, I think, hibernating squirrels that they studied in the lab, or other animal species, but someone got the idea to look at this in hibernating bears. And so some researchers actually went out and collected blood samples from bears during their hibernation and later on in the summer when they woke back up. These were measurements of tau in the blood. Again, I mentioned we can now measure these proteins in the blood and get predictions about what's going on in the brain. And it turns out they did have more of the tangle-like tau in their bloodstream when they were hibernated, but those levels fell back to normal during the summer. Very interesting observation. We don't know what it means. We don't know if that tau is protecting the brain while the animal's in hibernation. Is it a good response, or is it a not great response? But the good part is when the animal wakes up from hibernation, it clears it. And what's the secret of clearing that? Can we study that as a way of potentially clearing tau buildup in humans? So, can we figure out what that process is? And I think the other interesting question was, who was heroic enough to draw blood from hibernating bears and awaken them from their sleep to be able to collect these samples? So a lot more to be learned. I'm going to switch gears in the final few minutes and talk about some studies that don't have anything to do, or at least not directly, with amyloid or tau, but maybe have a little bit of a link with hibernating bears. Obviously, a hibernating bear might get rather upset if you awaken it and ask it to do something it doesn't want to do, like provide a blood sample. We also know that individuals with Alzheimer's dementia they can also develop agitation, particularly later on in the disease course where, being asked to get dressed or take a shower can be confusing tasks, and they can resist that care or react sometimes verbally or physically in an aggressive manner. And at this point, there are no approved medications for the agitation or aggression associated with Alzheimer's dementia. But that could change because there are studies looking at specific compounds. This is a study of a drug called brexpiprazole. It's used currently for treating disorders like schizophrenia, where people can have confusion, misperceptions that can be associated with agitation. But these individuals in this study all had Alzheimer's dementia with frequent aggressive behavior, and they received either a placebo or a daily dose of this medication, and they just measured how much agitation their study partner or family member reported while they were receiving either the active drug or the placebo. And in the end, those who got the active drug at either dose had fewer points on this agitation scale. It was about 5 fewer points, which means that either one disruptive behavior might go from almost a daily basis to almost not at all, or maybe 5 different behaviors that were happening several times a week were now only happening once a week. So it could have been a marked change in one behavior or a slight change in multiple behaviors. Any of those would have translated into a 5-point difference. So this looks promising, but I think the other thing that's very interesting is that everybody's score on the agitation scale dropped, even if they were just receiving the placebo. There was actually about a 15-point drop in the placebo group alone, and then an added 5-point drop in the treatment group, suggesting that just the benefits of being in a trial, working with folks who can help understand these behaviors or having that interaction, perhaps that itself was associated with less agitation. And that's obviously hard to replicate by simply giving someone a medication every day. So the FDA will review this, and it potentially may become the first medication approved to treat the agitation associated with Alzheimer's dementia. And then I'm going to just finish with a final few slides looking at non-medication trials related to Alzheimer's disease. Recently was announced the result of a trial looking at exercise, the EXERT trial. We know exercise can have a lot of helpful effects biochemically on the brain. And so the researchers wanted to know, did different types of exercise help individuals with mild cognitive impairment, individuals showing some memory changes, but still independent in daily activities. So not at the dementia level, but at the mild cognitive impairment level. And so they compared individuals receiving an aerobic regimen of exercise where they were targeting certain heart rates versus those who did more toning and stretching. And they hypothesized that those with the more aerobic activity would show less cognitive decline over time compared to just the toning and stretching. And as it turned out, both groups were remarkably stable over 12 months, whereas many individuals with mild cognitive impairment we'd expect to have a decline over that period of time. And so the conclusion would be even a modest or low level of activity, if it's stretching and toning, may help protect the brain cells. Or maybe it was some other aspect of the study, because these individuals were working at their local YMCA with trainers on a regular basis. So maybe it was the social interactions or some other aspect that also helped to preserve the memory over time, because we know from other studies, those types of activities, social rather than just physical activity, can be helpful as well. So Dr. Hiroko Dodge, who was previously with our Michigan Alzheimer's Center, she has done several studies looking at the benefits of social contact to individuals who either are older with normal cognition or have this mild cognitive impairment. And in her study, she arranged volunteers to have regular video or sort of Zoom chats. This was planned pre-pandemic, but became very important when the pandemic hit because they were able to continue the intervention. And so individuals either receive these regular video chats plus a weekly phone call, or the control group just had a weekly phone call, and they compare their cognitive scores. And those in the video chat group, if they started with memory impairment, they actually showed improvements on some of the memory measures over the 6 and 12 months that these interventions were being applied. And so you might say, well, gosh, what if we start doing all of these things together, not just regular exercise, but we engage with others socially, we follow a good diet, we treat our other health conditions, our blood pressure, or diabetes? What if we do all of these sort of lifestyle interventions? What might the outcome be then? That's exactly what the Finnish geriatric prevention trial, or the FINGER trial, did, where individuals received either very structured counseling about nutrition, exercise, they were engaged in cognitive activities, or they were just sort of told, we think it's good for you to focus on these, but there wasn't any structured interaction. And these were older individuals at risk for cognitive symptoms. They followed them over 2 years and showed better test scores cognitively in those with the more structured intervention, and a lot lower risk for certain health conditions, chronic diseases as well. This was in Scandinavia, but now is being replicated across multiple locations. So there are multiple finger-like studies being done. The one that's being done here in the US is called the Pointer Study, an acronym for protecting essentially the brain through lifestyle interventions to reduce the risk of cognitive impairment. So a very similar program where a large number of older individuals who might be at risk because of other health conditions or their age or their family history, but they either receive a very structured lifestyle intervention or just kind of a self-guided one to see if we can replicate that impact on cognitive function and ultimately other health conditions as well. So this is an ongoing study at several locations throughout the US that we'll learn about more in the coming years. But there's a lot more out there as well. So, I focused a lot on this part of the biochemical pathway, the amyloid plaque aggregation or deposition. Talked a little bit about this part, the tangles, but there's lots and lots of other steps that are going on in the brain when someone is developing the pathology of Alzheimer's. And this slide isn't meant to explain any one particular part of them, but just to say it's a complex disease. It's not just a simple thing where one change happens. There are a lot of things going on, which makes it challenging, but it also means there are many potential steps for which we could develop therapies or targets to intervene. And so we hope at the University of Michigan to be involved in some of these other treatments that maybe aren't necessarily directly attacking amyloid or tau, but other important aspects in these biochemical processes of Alzheimer's disease. So I'll finish with just mentioning some of the studies that I've been involved with or hope to be involved with. There are many, many more going on at the University of Michigan through our Alzheimer's Research Center that my colleagues are leading. So feel free to take a look at our website if you want to know what's happening right now. We were involved in the phase 2 trial of Lecanemab. As I mentioned, we've got a prevention trial using the drug solanezumab that is just finishing up, and one that is enrolling folks using Lecanemab as a prevention trial. We have other studies where we just follow folks without any specific intervention, but using some of these specialized brain scans to track how things progress over time. Some of these studies were the ones that led us to understand that amyloid can build up silently many years before symptoms develop. And in the future, we hope to be involved in some really sophisticated trials where compounds have been engineered to target, very specific parts of this pathway, like these sigma receptors here, and some using compounds that are a little more, I would call sort of natural or organic, like this medication or compound called benphthyamine. It's kind of an analog of thiamine, a normal vitamin that we have. There are reasons to think that in Alzheimer's disease, there might be insufficient levels of thiamine in the brain or related compounds. So giving a simple sort of natural supplement, would that help slow down the progression of Alzheimer's? So there are a couple of trials planned using these compounds that we hope to be involved with. And in the future, one looking at more specific therapies targeting the tau aspect in what's called a platform trial, where you can simultaneously compare different tau therapies or anti-tau therapies against a placebo, rather than having to do separate trials to sort of kind of speed up whether we learn if a particular compound is helpful or not. So as I mentioned, these are just some of the things that we're either doing right now or hope to be involved with. Many more available, so feel free to take a look at the Michigan Alzheimer's Disease Research Center website, specifically under the research part, to see what studies are enrolling now, and just keep an eye out there because we add more all the time. And with that, I will pause. I think we've got a few minutes if we are able to open up for questions.
Yeah, absolutely. Thank you so much. That was a lot of really great information. We do have time for a couple questions. So if you do have a question, you can go ahead and put it in the Q&A box, and I will pass that along to Judy. Oh, looks like we got one right away. Alrighty. This one says, given that drugs have demential side effects, I'm interested in finding out if the university has entertained or would entertain a clinical trial to replicate results of Dr. Dale Bresden's work that has produced stunning results in not just slowing and advancing in the advance of dementia, but in reversing the decline of cognition. His protocol isn't drug-based, and I would like to know if the university would ever consider such an approach to treating Alzheimer's.
Yeah, I think that's a really great question. So Dr. Bredesen has designed not necessarily a specific regimen, but more of an approach to treat Alzheimer's on an individual basis, taking into account a lot of the science that says, that there may be a different aspect of Alzheimer's that's more prominent in one person than another. So in one person, there might be a lot more inflammation, and in another person, it might be more oxidation or some other component. And so the idea of his approach is to do a lot of blood work and other markers related to these, and sort of design a specific intervention tailored to that person's blood work. And it also involves aspects of diet, or sometimes even caloric restriction, like not eating during certain hours of the day. So it's not a one size fits all, but it's sort of an algorithm. And so it makes it hard to study. How do you study it when each person is going to get a little different combination of supplements or things like that? But I think it really does deserve study, because right now what we're hearing is largely sort of anecdotal reports, not really rigorous scientific results. But I think it would have to be a collaborative effort, probably something more than any one center could tackle. But you'd have to think about it creatively. What's your comparison group? So maybe you look at all the different possible supplements that might be recommended. And in one group, you say, okay, we're going to do a very careful match to the blood work. And the other group, we're going to randomly assign some combination to see, is it really that individual tailoring that makes a difference? Or is it just doing something, focusing on your health helps you be better? And it really doesn't have to do anything with the specific compound. So I think that's a great question, but not a simple answer.
All right, I'm going to go into another question. Having read Sebastian Walsh et al.'s BMJ editorial, Lecanemab and Alzheimer's Disease, with the subtitle, New Trial Reports Little to Celebrate for Patients and Carriers, I'd like to hear Dr. Heidebrink's perspectives on the clinical meaningfulness of the amount of reduction in cognitive decline based on the clinical dementia rating that is reported in the pivotal trial, which seems to be an important consideration along with the trial's safety findings. The authors conclude, weighed against the scale and severity of adverse events and substantial practical barriers to widespread use, Lecanemab is unlikely to represent a favorable risk-benefit balance for patient or value for money for health systems.
Wow, that was a mouthful of a question, but it was very well proposed, because I think that's really the key question is, we have a drug. I think there's consistent evidence of a benefit in terms of slowing progression, but numerically that benefit is small, and we have side effects that we know. Again, most of the time, those are clinically silent, but if not adhered to carefully or monitored for carefully, they could become more problematic. And so ultimately, what's the risk benefit? And I think that answer is going to be different in different people. I think one way of posing it is the way I sort of suggested earlier. Would it have been worth it to you to be coming in every 2 weeks for this infusion if now at the end of the study you were back to where you were 6 months ago? And I think some people would say, absolutely, I could be doing this for 6 months longer. I could be doing that. I could be independent in these different ways. And what's the value of independence? How do you measure that? Other people would say, I didn't really feel that much different 6 months ago. I'm not changing much. I'm not sure it's worth it. So again, it's a very hard question to answer. I think everyone's going to have their own take. And we don't know whether that benefit might be greater as time goes on. That's an unanswered question at this point. I agree that this is not going to be the way we treat Alzheimer's logistically. It's just not a drug we can administer to the numbers of people who are even, potentially falling into that eligibility range. But I think it's a breakthrough in saying, we can do something on the amyloid basis that modifies. We just need to develop even more powerful, I guess, and safer drugs ultimately.
Great. Do you have time for a few more questions, Judy?
Sure.
Okay, great. Are there any trials looking at the quality of life?
Often that is an embedded measure in the clinical trials. So that Lecanemab study did include measurements where they asked both the participant about their quality of life, trying to rate it numerically, had their study partner provide a sense of what they thought the participant's quality of life was like. And they also had the study partner rate their own burden, so to speak, as a caregiver. How much of your time do you think is spent providing care for this person, and is that in any way, a detriment? And so those caregiver burden and quality of life ratings were tracked. Those haven't been published yet, to my understanding, but they did show a difference in the treatment group versus the placebo group. Again, a small difference, but those are things that are really hard to measure, trying to put numbers on quality of life. But you're right, I think that's an important aspect of trying to understand the meaningfulness of scales like that CDR.
All right. How long does the removal of amyloid last after treatment?
Another great question. It probably lasts quite a bit longer than just the last infusion. And we know that in part from individuals who participated in the phase 2 study of Lecanemab. Some got the active drugs at different doses, some got the placebo, they had pre and post PET scans, and then some were invited later on to enter an open label. But there was a lag period between when they finished the phase 2 and when they finished the open label, where everyone got the drug. And so if they got a new PET scan when they entered the open label, you could say, if they'd gotten the active drug and their amyloid was lower, did it stay lower for that year or 2 years when they weren't receiving further therapy? And the answer was yes, it did seem to stay low. So that is encouraging, that maybe you don't need to keep dosing forever with these agents. On the other hand, if you track their cognition, there was a sense that if it was being slowed down, that benefit was starting to slide when they weren't receiving the treatment. So yes, we may be able to keep the amyloid low even without continuous therapy, but whether the benefits persist is a harder question, but research is trying to answer that right now.
All right. Why did the number of participants reduce so much during the study of Aducanumab?
Oh, you mean looking at the numbers? I don't know if this is referring to looking at the numbers of people at different time points. Well, if that's the question, because the trials were halted early, not all people made it to the 18-month time point that they designed, and everybody enters the trial at a different time. You don't enroll all 3,000 people at day one. Some people enrolled, at one point, other people a few months later, and other people a few months later. You're continually accumulating people. They halt the trial partway through. Some people at that point have made it to 18 months, but it's only a fraction of those that they originally intended to follow the whole way through. So the numbers at each time point is smaller and smaller because the trial was halted early. So fewer and fewer people had the opportunity to get to those later time points. And there are other things that happen too. People drop out of the trials for any number of reasons. So it's common for up to maybe 15-20% of people not to finish a trial for all sorts of reasons.
All right. Wasn't there a research peer-reviewed journal article where an investigator manipulated data regarding amyloid plaque? Will that affect any amyloid clinical trials?
Yeah, that's another great question. That was another big news story in the past year. It was a publication looking at a specific form of amyloid, where the thought was that the actual scientific data had been either manipulated or the same result was published in multiple ways and not really reflecting unique data. many people had actually questioned that original publication because they was sort of identifying a toxic species of the amyloid. Several labs early on had said, we really can't replicate that. It was kind of one piece in the big amyloid puzzle, and no specific therapies were ever designed towards that specific species, in part because the early data couldn't be replicated. So the fact that that data may well have been falsified is a huge, it's a huge disappointment, and that, scientific integrity is so important. So that really does need to be reviewed and corrected. But fortunately, it didn't really change the larger course of treatments geared towards amyloid.
All right, here's another one. Because social contact is able to slow decline of memory, does the exert or other exercise trials have a beneficial effect merely due to social contact with exercise coaches? Is this why the balance group showed as strong results as the cardiovascular exercise group?
I think that is an unanswerable question, because you couldn't separate out the social contact from the exercise, since all of these exercise sessions were being conducted with that social contact piece of it, working with a YMC trainer, for example. So you'd have to design a separate experiment where you can still monitor people and know that they're exercising, like they have to turn on a Zoom camera when they exercise, and someone just, behind the scenes documents that they are exercising, but isn't actually interacting with them during their exercise, to be able to separate that component out. So we don't know which of those components led to the benefits, whether it was the combination, either one separately. Can't answer that question right now.
All right. Just a comment. I have observed a significant improvement of my husband's memory once winter ended last year and he resumed considerable biking and weight workouts. That, along with sunshine and more social interaction, really seemed to help. I'm glad to hear that it is not my imagination. Now we're looking into cardio equipment for indoor winter use. We already have a weight machine.
Perfect. Maybe you could describe that what your husband went through was sort of like that bear awakening from hibernation. It was, doing something biologically that was helpful as he got more light exposure, more exercise, all those other activities. So good for you.
All right. What are the risks of taking, okay, I can't pronounce it, benfotiamine?
Oh, the benfotiamine, yeah.
Which is available as a supplement.
Yeah.
If it doesn't prove beneficial, could Alzheimer's patients take it just in case there might be a benefit?
Yeah, I mean, in theory, that's true with a lot of supplements that people are proposing that might be helpful, whether it's a vitamin supplement, an anti-inflammatory, things that are over the counter. We'd really like to know, because some people are out there selling quite expensive version of these things. And so rather than just saying, what do we got to lose? We'd really like to know, partly because we want to know if it's helpful to prescribe it, but also to know in a rigorous way, are there side effects? Because without those studies, we're just relying on people just sort of anecdotally saying, hey, I tried it and it bothered my stomach, which is probably the most common side effect that we hear with most of these supplements. But we wouldn't know without rigorous study, are there electrical effects on the heart? Are there interactions with other medications? So that's why we really like to have that rigorous study to say, not only is it, not only does it help people, but we know it's safe to take and in combination with other things too.
Okay, one last question. Risperdal worked wonders for my loved one with AD as far as agitation and angry outbursts. It was a game changer. Have you ever recommended Risperdal for those same behaviors?
Yes, Risperdal is sort of in the same category as the drug that I mentioned. And so we will, in many cases, use those types of medications because we know on an individual basis, they can be helpful. Unfortunately, there isn't a magic one that works for every person every time. And, that's partly why there hasn't been a drug that's approved yet, because when you study groups of people, they don't all behave the same way. But yes, since we don't have any technically approved therapies for the agitation and behavioral challenges, we resort to using medications that we think might be helpful even without that FDA stamp of approval.
Okay, just one more. I fibbed.
That's
okay. Right. Is it true that general anesthesia causes p-tau to elevate?
Oh, I think I would say I will defer on that one. I mean, there are a lot of interesting questions about anesthesia and whether its effects are only temporary, turning the mind off and rebounding afterwards, or whether there are any links to any Alzheimer's type changes. Some of the things that I had heard about were related really more to inhaled anesthetic agents that we don't use anymore. So at this point, I would say there's not anything convincing in my mind that an anesthesia is a direct risk for Alzheimer's changes, but a lot more is being done to look at that.
Okay, I think that is all that we had. Be on the lookout for an email that will come out. I will be sending out an evaluation for this, so it'd be really helpful. We like to make sure that we're serving everybody properly, and I'm glad everybody had a chance to attend. So thank you so much for coming.
Right. Thanks, everyone.